Thank you. So my task is to discuss the role of additional drug in addition to 5-FU for the 5 or 6 weeks period of preoperative chemoradiation. Traditionally, the studies who have done post versus preoperative chemoradiation, the German trial and the GICC trial and some other trials, they used the various types of 5-FU for radiation. I will not discuss this intravenous 5-FU schedules. They are really different and in all trials and difficult to compare. However, we can say a standard dose of 5-FU is something what is active together with radiation. There is no clear role of dose schedule type. We only know that from the postoperative trials that the chemoradiation with 5-FU continuous infusion while radiation is superior to bolus 5-FU. That's all what we know. So 5-FU is used in different ranges and it's called standard. The question is, what about the capecitabine, oral 5-FU? And the second question is about the oxaliplatin or irinotecan or the targeted drugs. The study from our German IO group comparing 5-FU post and preoperative with capecitabine showed a slight superiority of capecitabine over 5-FU, which was significant in 5-year DFS. However, the control arm, again, it was a question of whether the IV 5-FU, which was, I think it was bolus, was a standard dose or optimal dose. So all what we can say from this that capecitabine is at least comparable to IV 5-FU for DFS and overall survival. Local relapse rate is the same, and distant relapse rate as well. This has been 392 patients, and the NSABP study, the final data has been shown recently at ASCO GI this year. This is the largest study comparing 5-FU, continuous infusion over 5 weeks. That's a low dose continuous infusion, not an intermediate dose like in the German trial with 1,000 milligram over 5 days. This is a 225 over 5 weeks, over 5 days weekly. So it's a continuous infusion over time. And comparing the second part of the study, oxaliplatin, plus or minus oxaliplatin. The dose application has been well in all arms. The oxaliplatin was less with a little bit less with capecitabine, indicating that it's more toxicity of oxaliplatin with capecitabine together. Radiation dose was more or less full dose, and 80% of the treatment was given. This is the part of the result for the capecitabine versus 5-FU. There's no difference, no significant difference. Capecitabine 20.7% pathological CR rate, and 5-FU 7.8%, so it's identical. The 3-year overall local regional recurrence rates are any event or just the local recurrence was same again, and it was, by the way, low in the study, despite American surgeons have been claimed not to make good surgery, but this shows they do good surgery and do good chemoradiation with 3.8, 3.6% local relapse. The 5-year outcome is again the same for DFS and overall survival for 5-FU and capecitabine, always favoring a little bit the capecitabine arm. The curve for local region control is no difference even after long-term follow-up of a maximum of 8 years now. And again, it is a large study with more than 1,600 patients. Hazard ratio 1. The overall survival, no difference. So these data show clearly that capecitabine is comparable, equivalent to 5-FU, and is easier to give, and therefore should substitute the IV 5-FU for chemoradiation. The second question is, so this question is answered for capecitabine. The second question is oxaliplatin. There have been done 5 trials, more than 5,000 patients. It's an enormous amount of patients for this question of oxaliplatin. The first has been the STAR trial and the ACCORD and PRODIGE-2 trial, which have been relatively large studies as well. And you see here very clearly that what we know, there's no difference for the pathological CR rate in the STAR trial for oxaliplatin. Our zero rejection rate is a little bit higher, with 97%, but it's high anyway in these studies, in all of these studies. We have no report about local relapse rate and disease survival from the study. It will come probably later. I did not see the data until now. The ACCORD trial reported all the final outcome. Again, we have to say that this is only the local regional control rate of a local regional treatment. It's not systemic treatment. In the ACCORD trial, 50% of the patients had some 5FU adjuvant therapy. The STAR trial is unknown how many had really adjuvant treatment. They have not been randomized for adjuvant treatment versus no adjuvant treatment, or adjuvant 5-oxaliplatin versus no adjuvant oxaliplatin. So the result relates only to the local outcome, and we don't know what is the final outcome influenced by the additional adjuvant treatment, which was not randomized in these studies. The ACCORD trial showed a significant improvement for the local PCR rate, which for the nearly PCR was not significant, borderline significant, but it was significant if the microscopic residual tumor cells have been included. It's called nearly CR, which was 29 and 39%, relatively high. So this was a somewhat positive result. The RZ resection rate is accordingly a little bit higher, 87 versus 92%. Local relapse rate is something less, but not significant, with 6 versus 4%. The disease survival is improved, but not significant, 72.7 or 73% versus 68%. This is something which we expect in such a large trial, and typically large trials, to be significant, a difference of 5% in final DFS after long-term follow-up. But with this 598 patients, it was not significant. But this is a study which could show a trend in favoring the role of oxaliplatin while this 5 weeks of pre-op treatment. However, formally the study is also negative. Then we have 3 other trials, the NSABP-04, which I show in a second, and the German trial, 04, RO-CAO-ARO-04 trial, and the PETAC6 trial, which was the last one on this row, and indeed the last one. So these are the data which have been reported 2 months ago at ASCO GI. No difference for oxaliplatin. It is formally no difference, P0.42. Oxaliplatin has 19.5% PCR rate versus 17.8. There is some difference favoring oxaliplatin, but it is not significant. Local recurrence rate after any event, and the only local recurrence, it's a trend, small trend, which is a little bit less. The 3-year event rate is less for oxaliplatin, but in general, it's not statistically significant and a marginal difference. So in conclusion, there is no difference favoring oxaliplatin. Again, for the 5-year outcome, no difference for DFS and for overall survival. These are the curves for the local regional control. Absolutely no difference in the log rank comparison for oxaliplatin, yes or no, independent of the 5FU partner of this combination. Survival, the same, no difference for oxaliplatin versus no oxaliplatin, independent of 5FU or capecitabine. The Toxicity clearly is expected to be higher with oxaliplatin, and diarrhea is doubling, grade 3-4 diarrhea is doubling from 7 to 16% for the oxaliplatin combinations, independent of the study of capecitabine or 5-FU. The toxic death rate is increased to 1.6%, but it's a little bit higher with the capecitabine as single agent as well as capecitabine plus oxaliplatin, indicating what we see in the PETAC trial, that there's capecitabine oxaliplatin is not an easy combination, in particular if it's given with radiation. Finally, the PETAC-6 trial, I give in more details because it's an EOTC trial, or PETAC-6 EOTC is a trial, has been reported for the data for the local response, and the final data will be reported, not the final, the pre-final or the interim data will be reported for DFS and ASCO this year. The design of the study is also very clearly straightforward. T3-4 or class and positive disease, so locally advanced rectal cancer, below 12 centimeter from the anal verge. Randomized to capecitabine radiation or capecitabine oxaliplatin radiation, followed by surgery and followed by adjuvant treatment, capecitabine versus capecitabine oxaliplatin. This is adjuvant treatment randomized, same like the German trial, the TOOS trial, which investigated the role of oxaliplatin as adjuvant treatment in comparison to 5-FU or capecitabine, but I do not show the results of this. It's too early. First and second will be reported at ASCO for the first time. The patient population, 1,094 patients, is a typical patient population with predominance of male, and the age range is going up to 87 and 82 in a multi-center, multinational trial, which is a challenge. The performance status was good in almost all patients, according to the protocol. The distance from tumor to anal verge, less than 5 centimeter in 43% of the patients in both arms. So all is very much balanced because it was stratified for these parameters. But just to show which patient population is here, the MRI was not used in all patients. 35% had endorectal ultrasound and CT only. Also, it was preferred and recommended to do the MRI, but this is a problem of availability in some countries. The T-stage T4 only 7% in both arms. The majority, or 92%, had T1, 2, 3, and N positivity in 70% in both arms. So it's a typical distribution of these patients in these trials. Stage 2, 21%, 22%, and stage 3, 70%. The compliance to the preoperative radiotherapy was good, as in the other trials. No problems with toxicity, and prematurely stopped only in 4% in the combined arm versus 2% in the capecitabine alone arm, which is not a really difference. The relative dose of oxaliplatin in the preoperative chemotherapy is reduced to less than 90% in 20% of the patients, which is for capecitabine, which is much more than in the capecitabine single agent arm, which indicates a problem with toxicity of this combination. The standard dose, 19 to 110, only 1/3 of the patient, but some patients, 1/3, had higher dose than the calculated dose, which was even more in the capecitabine single agent arm. Relative dose of oxaliplatin, standard dose in 72% of the patients, and 1/3 or 1/4 of the patients had less than 90% of dose due to toxicity. Safety, mainly grade 3, grade 4 diarrhea is a real problem, with 6% capecitabine versus 18% for capecitabine oxaliplatin. This is the same like in the other trials. It's not higher than in the 5-FU IV infusion or bolus based trials, but this is probably the reason why many patients had dose reduction. Postoperative complication rate was not significantly higher in the oxaliplatin arm. Toxic death within 60 days after surgery, which is a relevant marker, was the same in both arms. Now we have a problem since many data are not really analyzed, and this is an ITT analysis which includes all patients, even those who had no surgery documented and all these things. The resection rate was less than in the oxaliplatin arm, is 91% versus 95%, and the histopathological R0 resection was less, significantly less, in the oxaliplatin arm. The past CR rate was a little bit higher, with 13% versus 11.5%. Sphincter preservation was the same, numerically something less. If we look on the reasons why patients had not surgery, I think I should not go through this because we are still evaluating these data in detail. There have been protocol discontinuation due to progression in much less patients in the oxaliplatin arm, not much less, 3 versus 8 patients. And, but toxicity was more common reason to stop a protocol. Intercurrent deaths, 3 versus 0%. So it adds the reasons why patients stopped the protocol or went off protocol. This is a secondary analysis, which is what we like much more, not the ITT, but the reality. We still work on the data and check the individual patient data. This is the pathological zero resection rate in those who are the data available, and this is a 96% versus 96%. There's no difference. Past CR rate 12 versus 14%, no difference, and sphincter preservation same, 72%. If you looked on the patients who have been judged by the surgeon to be able for a sphincter preservation surgery before treatment, and then looked on what came out of this, sphincters preserved indeed. This is less patients because we have this judgment only from the 2/3 of the patient. The preservation in FICT is not different, 6% versus 82%, 86% versus 82%. So again, oxaliplatin did not increase the clinical data on sphincter preservation. So therefore we have 5 trials now together with the ARO, CRO, trial, which is the only one which showed clearly in the local response, the PCR rate, a significant difference, which was 0.045, which is significant, and the overall R0 resection rate is the same in all studies, more or less. There's no major difference between both arms in the R0 resection rate, which is high in most trials anyway. The local relapse rate we have only for the ARCOT trial, 6% versus 4.4%, not significant, and the NSABP 4.7 versus 3.1, which is not at all different, and we do not have the data in the moment from the ARO and PETAC6 trial, which will be expected in the ASCO this year. So in a few weeks we will have the data from the local labs as well as the data from the DFS. The PETAC6 data will not come as a final data, will come as early data, but we have the final data from the trial this year. So in total, there is no major signal or no real signal that oxaliplatin adds something to the local regional control of in combination with IV or oral 5-FU. One out of 5 trials has a difference in PCR rate, but not difference. Not the final data. So what about irinotecan? Capecitabine irinotecan has been done in small series, and this looks between 9 and 27% PCR rate with a high R0 resection rate comparable to the oxaliplatin trials. there is Aristotle trial, Rob Glynn Jones probably is still running the Aristotle trial, which is investigating the irinotecan part. However, if you look on all these data, we would not expect a major difference in outcome. What about bevacizumab? Several phase 1, phase 2 trials have been done with small number of patients, and the pass CR rate is ranging from 16% to 36%. This is a small number, different patients, very high risk versus intermediate high risk patients, mixture of patients in the studies. Our own is the last one, which is the largest with 66 patients with capecitabine, oxaliplatin, bevacizumab combination, while radiation, standard dose radiation, is coming up with 17% PCR rate. So a higher number of patients, less PCR rate, standard patient population. So from this also it looked in some early data promising. If you look on this mixture of data, we will not draw the conclusion that bevacizumab will add something major for radiation to 5-FU or capecitabine chemoradiation. The last question was cetuximab, and there have been done several trials. Some of them are analyzed for KRAS. Some majority could not be reanalyzed for KRAS. It seems to play not a major role, but altogether the data for the total patient population with standard radiation with capecitabine, oxaliplatin, capecitabine irinotecan plus cetuximab are not very promising. High diarrhea rate, the highest which we have seen in these pre-op chemoradiation trials, and the lowest PCR rate which we have seen in these trials. So even if it would go higher, if patients would have been separated for KRAS mutation or wild type, this could probably be higher than 9%, could be even doubling, but even then the PCR rate is not good. So this seems not to work together with these chemotherapies, and the question is why. The same question for oxaliplatin, why it doesn't work together with radiation and why it does not add it to the good effect of the 5-FU or capecitabine. This is unknown, and I will not start to speculate about this. We have to look on the genomic markers. This is one of the analyses which have been done, or recent analyses which have been done in rectal cancer from the German group from the previous trial, looking on those who have benefit from the treatment. This is just a prognostic marker, but they also work on the predictive markers. So the essential part of the recent RO, CRO, and ARO trial, as well as the PETAC6 trial, is the molecular analysis of the genomic analysis of the primary tumors, which is the problem because you have the biopsy, and then we have the tumor which is treated by radiation and chemotherapy. And the question is, how relevant is this? And the biopsies are so small, very often to make good investigations. But this is scheduled for at least in the large trials, and extremely important. If you can see here, these three groups which have been seen in a small validation set to be prognostic, very strongly prognostic. There might be a major difference in the groups, and probably there is a role for oxaliplatin if you look in subgroups, which is still open. Conclusion, no role of oxaliplatin or any other drug in addition to 5-FU, or preferably capecitabine, after we have this large body of data favoring capecitabine. The question is what we do with these results if one of the, or both, or one of these at least, PETAC6 or German trial is positive for disease survival. There would be positive having oxaliplatin plus irradiation, capecitabine irradiation or 5-FU irradiation, and they had oxaliplatin for adjuvant treatment. How we can dissect the influence of oxaliplatin in while radiation and while adjuvant treatment will be not possible because there's no third arm having only 5-FU for radiation and oxaliplatin only for the adjuvant treatment. So this will be difficult if one of the studies at least will be positive, and we have to discuss this if in this case. We will know soon. And the genomic analysis is essential to find out the subgroups in the future. Thank you very much for your attention.
you very much, and we will continue with the last speaker.